We will start the Hyde Park session on Vitreo, Retina and Uvea. So it is a competitive session with 4-minute presentation time. Automatically it will be cut after 4 minutes, so be careful about that. First one is by Dr. Chittaranjan Misra. First one. ILM detachment in acute CSCR, central retinal artery occlusion, CRAO. Which one?
प्रेजेंटेशन कहाँ है इनकी? इधर 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 देख लीजिए। आप प्रेजेंटेशन देखिए।
Audio visual people.
Audio visual जगह देखिए। प्रेजेंटेशन इधर।
Chittaranjan Misra, no? First one.
हाँ.
Yeah.
चित्तरंजन मिश्रा?
Yes, sir.
Good.
This is something else. This is something else.
This one. You have to go this side.
अच्छा उधर जाइए।
Should I start?
Yeah.
Hello everyone. My talk is on internal limiting membrane detachment in acute CRAO. So the detachment of ILM as a biomarker in acute CRO has been described in recent literature. The proposed mechanism is that severe retinal ischemia leads to biomechanical changes, especially the Muller cell changes, which leads to this pathology, and this has been described as a poor visual prognosis. This study was a hospital-based retrospective case series, and patients other than other retinovascular disorders were excluded. All the patients underwent OCT macula comprehensive ophthalmic examination and 3-month follow-up. So to highlight, over 3 years out of 96 acute CRO patients, 6 patients had these OCT biomarkers, and all the patients had macular edema. The central macular thickness and maximum macular thickness were slightly different, as I have mentioned over here. CMT was 492 and maximum was 687. I will show in the next slide with the pictures. And most of the patients were young patients. If you can see this slide, almost all the patients are young males. So there is some gender predisposition also. Systemic risk factors, except one case, other cases we could not find any. Smoking was present in 50% patients. All the patients has very poor vision during presentation, which was there in the final follow-up also, except one patient which had a patent silveretinal artery. And all the patients had macular edema. And interestingly, 2 patients developed stroke during follow-up. So this is the slide which we can see. Almost all the patients, as we can see over here, they had the internal limiting membrane detachment and macular edema. We can see this is acute CRO like OCT picture, hyperbolic inner layers are there. And the last picture, the right side lower picture, we can see there is a patent silveretinal artery. So coming to the discussion, the ischemia of Muller cells leads to the internal limiting membrane detachment. But Muller cells span all through the retina, all of us know. Why not all the layers? At least in one case, we can see over here intraretinal fluid, and CME is also there in addition to internal limiting membrane detachment, which shows that maybe all the layers are also affected. But we could not see this finding in almost in all other cases. And second thing what we want to discuss is that all the patients presented with a very poor visual acuity during presentation, but if silveretinal is patent, we can have a good vision, which was 6/12 in this case. And another finding is that this ILM, sub-ILM fluid, according to the 2 previous studies by Jain et al. And Venkatesh et al., they had told that it's a clear fluid, but in one case it was a turbid fluid is there. The exact cause I don't know, maybe some future studies will highlight on this. And another thing is the gender predisposition, as I told, the previous 2 studies, they have told there is slight male predisposition. Why exactly also it needs to be answered in future studies. And systemic risk factors, interestingly, are less, we cannot find out in almost all the cases. So the limitation of this study is that it's a retrospective study, small sample size and limited follow-up, and the FFA, OCTA were not done in all cases. To conclude, ILM in detachment in acute CRO is associated with macular edema, probably resulting from the severe ischemia. Patients with poor vision and visual prognosis is bad. All the patients were male in this series. Not identified risk factor poses the other eye at risk, and possibly associated with increased incidence of stroke. Thank you.
Thank you, Dr. Chittaranjan. There's no hypothesis on why this happens, no?
Sir, what I could see, the previous 2 studies are there, 2 or very limited studies. They are telling that it is because of the Muller cell ischemia it is happening. But the counter thing is that if Muller cell is causing this, then why not all the layers?
Cases.
All the layers. So
it's very unusual, like ILM detachment in What is the
CRA.
pathogenesis of this? Because various ischemic diseases, they don't have ILM detachment.
Yes, ma'am. Yes, ma'am.
Yeah.
So, but this is a this is interesting finding, and out of 96 cases over 3 years, we could find only 6 cases. So it's a small proportion of the cases that present with this.
Maybe this may be responding to arterial decompression surgically. There are some, I don't know, I am just...
Yes, sir. In CRO, some surgeons have told about, in fact, last APVRS Hong Kong also, the award-winning lecturer was the Japanese doctor. He was given for the CRO decompression surgery he is doing. But in this case, we have not attempted surgical thing. We have excluded all other things, like it is not a mixed or combined mechanism. That's why I highlighted that.
No, was there ERM in these? Because ERM, if it detaches...
No. It was ILM, ma'am. We can go to that thing also. It is ILM pakka. It's not ERM.
Thank you, Dr.
Thank you, sir.
Suranjan.
Thank you.
Take-home message is send for stroke clinic. Many of us for CRAO, we send to cardiology evaluation. They will do echo and ECG and say everything is normal. But stroke clinic evaluation is most important in CRAO. We will go to the next case, PAM case series by Sanskrita Sinha.
Is Sanskrita Sinha present? Next.
Not there? Sanskrita Sinha?
Abhi aa jayega.
Oh, okay. Then we'll go to the next one. Macular edema due to multiple sclerosis medication.
Pone ovary.
Pone ovary.
Dr. Raminder Singh. Dr. Raminder Singh is present.
Dr. Raminder Singh? Absent.
Next.
OCT markers and their application in evaluating anti-VEGF response in type 2 diabetic maculopathy. Dr. Varsha. Okay, Dr. Varsha is
Idhar
here.
presentation, idhar this side.
Yeah, this is something else. So I will just announce the next presenter, post-dengue retinopathy, Advaitya Biswas. Is there? Yes, okay, get ready. Next. Yeah.
Good evening, everyone. My topic is OCT markers and their application in evaluating anti-VEGF response in type 2 diabetic maculopathy. Diabetic retinopathy is an important cause of preventable blindness. Maculopathy is damage to the macula, the part of the eye that allows us to see centrally. Diabetic macular edema is the most common cause of decrease in vision due to diabetic retinopathy, which affects approximately 7% of all diabetic patients. This study is conducted to identify OCT biomarkers that are valuable for clinical diagnosis and management of diabetic macular edema. This study is prospective observational study, included 100 eyes of 100 patients. Inclusion criteria were patient between 40 to 80 years with type 2 diabetes mellitus, no prior intravitreal anti-VEGF injection. Exclusion criteria were any active ocular infection or any pre-existing retinal or macular diseases other than diabetic retinopathy or macular edema. Factor under evaluation are submacular detachment, cystoid changes in inner and outer nuclear layer, integrity of inner segment and outer segment junction, hyperreflective foci, vitreomacular interface, and drill. Patients were followed up at 4, 8, and 12 weeks post-injection. Repeat dose of intravitreal ranibizumab injection were administered at 1 month interval in patients whose central macular thickness remained more than or equal to 275 micrometer. Result. For purpose of analysis, they are divided into two groups. Group A had good visual outcome, that is defined as more than 10 letter improvement or vision improvement to 6/6, included 38 patients, and in group B had poor visual outcome, that is less than 10 letter improvement or no improvement or worsening of visual acuity. In this 62 patients were included. We compare the following baseline OCT characteristics between two groups. Subretinal fluid. Presence of subretinal fluid at baseline was found to be statistically significant. Group A had 81.4 presence of subretinal fluid compared to 43.2 of Group B. Integrity of ISOS junction, no comparable difference in between groups. Group A had 26.4 and in Group B 90.5 percentage people have no difference. Presence of hyperreflective foci. Presence of hyperreflective foci and their location were analyzed between groups, but there was no significant difference. Hyperreflective foci was present in 76.4 and in Group B 81.6%. This was also not statistically significant. other biomarker drilled. There was no comparable difference between two groups at baseline. However, at 1 month and 3 months, the number of patients with drill decreased to nearly half the number. However, this change was also not statistically significant. Vitro macular interface abnormalities. Majority of patients had an intact in vitro macular interface, and there was no difference between two groups. Epiretinal membrane, both groups had very few patients with epiretinal membrane, and their presence had no significant difference. Cost line, that is cone outer segment tip line, presence of intact cost line was also not associated with significant change in visual outcome in our study. Discussion. Some studies like Sophie et and Ficker et al. Have reported significant improvement in visual acuity when subretinal fluid was present. However, many other studies like Simura et al. And Seo et al. Have found no difference or even associated with worse functional result. In our study also, presence of subretinal fluid was single most important biomarker in predicting good visual acuity response to anti-VEGF injection. Conclusion. Presence of subretinal fluid was found to have most significance in predicting good visual acuity response to anti-VEGF. Drill was found to decrease during treatment, but predictive rule could not be demonstrated. Thank you.
Thank you, Dr. Varsha. What is new in your study compared to all the available data?
सर न्यू तो नहीं है, बट डिफरेंस स्टडी में डिफरेंट रिजल्ट्स आए हैं. किसी में सब रेटिनल फ्लूइड के वजह से प्रोग्नोसिस बेटर होती है, बट सम स्टडी में इसके प्रेजेंस के प्रोग्नोसिस पुअर भी है. तो सर डिफरेंट मार्कर्स डिफरेंट स्टडी में सर है. सर मेरे फाइंडिंग में ये बेटर प्रोग्नोसिस.
Okay.
थैंक यू.
And next presenter, Dr. Aditya Biswas on post-dengue retinopathy.
दूसरा लगा.
Yeah, I think it is there. It is there.
No, it is here only, but
नहीं, वो तो नेक्स्ट वाला लगा रखा है. सीरियस ऑकुलर एडवर्स इवेंट्स विद इंट्राविट्रल ब्रोसिस मैप.
good evening everyone. I'm Dr. Aditya Biswas from RP Center AIIMS New Delhi, here presenting a case of post-dengue retinopathy. It was a 26-year-old female who presented to our center with no previous systemic illness and no apparent history of trauma. She had a history of dengue, NS1 positive 3 weeks prior, her chief complaint, and was treated for the same. There was chief complaint of bilateral painless progressive diminution of vision for the past 2 weeks. The systemic investigations which were done 3 weeks back showed a platelet count of 21,000, dengue NS1 positive and lymphocyte of 46%. All the other hematological investigations were within normal limit. Slit lamp findings showed best corrected visual acuity of 624 and right eye, and in the left eye it was 660. IOP, the adnexal structure and anterior segment was within normal limit. There were no cells and flares. The indirect ophthalmoscopy of both eyes showed multiple intraretinal subhighlight hemorrhages involving the fovea. The opto-CP image of the same patient shows in the right eye a subhighlight hemorrhage in the center, and in the left eye similar at the subhighlight hemorrhage at the macular, and there are superficial hemorrhages, intraretinal hemorrhages in the periphery. The OCT findings shows a subhighlight hemorrhage in this cross section and a superficial intraretinal hemorrhage in this cross section of the right eye. In the left eye there is a subhighlight hemorrhage which was seen. So our diagnosis was bilateral post-dengue retinopathy. Our plan was observation. On 3 weeks follow-up, we saw clearing of hemorrhages and the best corrected visual acuity was 618. On 6 week follow-up, the right eye best corrected was 612 and left eye best corrected visual acuity was 69. So on follow-up we see there is a right eye, there is an old hemorrhage present at the macula, and in left eye there is some macular pathology, but it is not seen exactly on optos. In the right eye, as it was seen in the opto-CP, in the macular OCT similar findings are seen of an old hemorrhage. In the left eye we see some kind of cystic space which has been formed in the macula. Probably it's an impending, it will impend to an lamellar macular hole. So dengue virus can manifest clinically in the eye as either ocular inflammation or as hemorrhagic complications. Ocular manifestations of dengue are subconjunctival hemorrhage, uveitis, serous RD, choroidal effusions, retinal hemorrhages, and macular edema. Ophthalmic complications are usually seen in young adults who often present at the nadir of thrombocytopenia between 1 to 2 weeks after onset of symptoms. The take-off message is post-dengue thrombocytopenia can cause retinopathy, which can resolve spontaneously. OCT reveals persistent retinal changes. Patients should be kept in close follow-up to look for spontaneous resolution. In most cases, spontaneous resolution is noted. Intervention is not required. Thank you so much.
Thank you, Dr. Aditya. Actually, the other finding that is reported in dengue is foveolitis.
Yes, sir.
This is due to the coagulation abnormality that is coming, this pre-retinal hemorrhage.
Yes, sir. The 21,000 thrombocytopenia.
Yeah, that is real dengue retinopathy is probably due to inflammation.
Inflammation.
In foveolitis.
There was the anterior segment was clear. There was no cells flare, and there was no RL cells in the posterior
So you
segment.
look for both.
Yes, sir. Thank you so much.
Dr. Mrinalini Singh. This side, this side. Next presenter is Dr. Parth Mehta. Is there? Yeah.
Good evening everyone. I am Dr. Mrinalini Singh from Army Hospital Research and Referral. My topic for today is serious ocular adverse events with intravitreal brolucizumab. We have conducted a prospective observational study since 2021 at our Tertiary Care Institute. After obtaining IEC approval, we have taken informed consent from around 1400 patients before including them in our study. Brief about the molecule. It's a 26 kilodalton humanized single chain antibody fragment against vascular endothelial growth factor A, which was approved by US FDA in 2019 for intraocular use. It was launched in India in October 2020. Various studies like Hawke and Harrier and Kestrel and Keat, they have established non-inferiority of brolucizumab from aflibercept in visual outcomes. The brief mechanism of action, it attacks its action on VEGF-A and it inhibits its interaction with VEGF-1 receptor 1 and 2 and curbs the endothelial cell proliferation, neovascularization and vascular permeability. This study was required as AMD burden and treatment in India may suffer regional and genetic disparity from various Western populations, so it's relevant for our population. Studies like Hawke and Harrier in their phase 3 trials have reported various ocular adverse events with brolucizumab like endophthalmitis, retinal detachment, vitritis, anterior chamber inflammation, etc. In our study, we have used brolucizumab for AMD, PCV, diabetic macular edema and macular edema related to vein occlusions. Ocular adverse events after intravitreal brolucizumab injection were monitored for 36 weeks at every 4-weekly review and SOS. Other parameters measured were BCVA and OCT macula. Best corrected visual acuity showed a change of minus 0.13 mean change from pre-injection levels to 36-week post-injection. After experiencing failure with many of the other anti-VEGF agents, brolucizumab has brought many success, but with some adverse events which we have scored like 0, 1, 2, 3 and 4. Score 1 they required they did not require any oral NSAIDs. Score 2 required pain relieving NSAIDs. Score 3 with some aqueous cells and flare. And score 4 were some serious adverse events which manifested as vitritis, hypopyon, Seineke formation. This is a result from our study in which the frequency of adverse events is depicted by, in a bar diagram. Most of the patients were asymptomatic and the findings were incidentally detected on follow-up visit. Out of the total 1420 injections administered, 4 patients had score 4 serious ocular adverse events, 2 of which were NAMD and 2 were DME. Score 3 patients were 45 cases, comprised 3.2% of our cases. 4 cases had score 4 adverse events, 0.3% of our cases. One of our patients was a 65-year-old female with PCV in both eyes. She developed vitritis on after 72 hours after injection, second injection, and she was managed with oral prednisolone and tapering dose of topical steroids. She developed reaction to anti-VEGF for around 8 months, and currently she is maintaining 618 vision with aflibercept. A case 2 was 72-year-old male with type 1 MNV, developed vitritis after the 6th injection, managed with oral prednisolone, which was resolved by 5th day, and the patient accepted brolucizumab reaction. Case 3, CDME, 66-year-old male, managed with oral local steroids, and due to the diabetic status of the patient, and maintained a BCVA of 6.9. The results from our studies that the brolucizumab is a newer anti-VEGF agent which is safer to use in our population, and around it can give an incidence of around 0.3 to 0.4% of intraocular inflammations, and which can be managed very easily, and we can give promising results in visual acuity to the patients.
So what are the other effects? Only inflammatory you have observed 3.
Yes, ma'am. Other effects were only minor, like subconjunctival hemorrhage, minor pain. No patient developed endophthalmitis or any severe reactions like some severe retinal detachment. These were not observed. Only inflammatory responses. 4 patients were observed with serious inflammatory response. Most of the patients were asymptomatic, sir. We have
then what is your follow-up protocol? Because if the patient is asymptomatic, how will you how do you follow up the patient in
sir,
after brolucizumab?
we have made a protocol for 4 weekly follow-up, sir. For around 36 weeks, every 4 weeks we ask the patient to review.
Whichever be the injection?
Yes, sir.
Not after first week or second week? Nothing like that?
No, sir.
Okay.
After the first injection, we call the patient after.
So you may be missing a lot of people who come after 1 month.
Because
sir, most of our patients, they are asymptomatic, but even after.
So you may see some asymptomatic like small vasculitis or something. So the problem in, I agree that problem in brolucizumab is the timing is very difficult to find. Some people say after second injection, after
Sir.
3rd week only it will manifest.
Sir.
So that is, there is no difficulty.
Sir, even one patient developed after 6th injection.
6th injection.
In the second
And
week
that
also patient has developed.
The one you showed after 3rd day, that looks real infective endophthalmitis. that is usually
Sir,
in
but
brolucizumab
that patient was easily managed with oral
Steroids.
steroids. Yes, sir.
How to differentiate vitritis from endophthalmitis? Also very basic question.
yeah, it is. It's very difficult.
It's
because
very difficult.
sometimes
Yes,
you overdiagnose and give intravitreal so the patient may not develop. But vitritis and endophthalmitis is very difficult to diagnose.
Yes, ma'am.
Ultrasound also doesn't show anything, and
Sir,
clinically
but
also.
when we have a background of we are knowing.
No vasculitis has been seen.
No, sir, not in these patients. They were managed with steroids.
So in some patient vasculitis has been reported in literature.
Yes, sir.
What
There
is
is
the cause?
there is.
What is the cause? I'm just asking. Vasculitis has been reported in these cases, no?
Yes, sir.
Because of
inflammatory, probably
Inflammatory response, sir.
just for
One advice is when you present your data, it's a very good data. You should not go around the history of brolucizumab wasting time.
That is, you are wasting time.
Wasting time.
You
Your
should not
study,
waste
you should
time.
concentrate more, so that it's a very nice study that findings and the numbers should be
Sir.
just
Arjun teacher है focused होना चाहिए.
thank you, nice presentation, nice. Probably you will need more subgroup analysis.
Thank you,
So
sir.
we will go to the next one, Dr. Parth Mehta, who will be talking on multimodal imaging in idiopathic retinal vasculitis, Irwan, 4 cases.
Good evening to the esteemed panelists and to everyone present here. Today my talk will be on multimodal imaging and management of 4 cases of IRWAN. The acronym IRWAN was given in 1995 to describe idiopathic retinal vasculitis associated with neuroretinitis and characteristic vascular changes such as Hyde knot-like aneurysms, capillary non-perfusion areas, and in advanced stages neovascularization of the retina and the optic disc. Purpose was to describe the multimodal features and treatment in these cases. It was a retrospective chart review of 4 cases who underwent serial fundus photo imaging, fundus fluorescein angiography, and OCT analysis over a period of 4 years. All the patients were evaluated completely along with vasculitis and systemic evaluation. Case 1 is of a 32-year-old male who presented with floaters in both eyes and drop in vision in the left eye with no systemic illness. Vasculitis workup was negative. Right eye shows multiple hard exudates and aneurysmal dilatation of vessels at the optic disc and along the blood vessels with capillary in non-perfusion area seen on fundus angiography and hot disk seen on FFA. Left eye showed similar features, but it's all features of IR1. The patient was started on mycophenolate mofetil 500 milligrams along with tapering dose of oral steroids. On follow-up, there was response to treatment and there was reduction in exudate seen in both eyes. The left eye developed a scarred choroidal neovascular membrane seen on SSOCTA. Right eye was subsequently involved 6 months later with presence of macular edema. Due to risk of traction in view of pre-existing fibrosis, peripheral laser was done before anti-VEGF in both the eyes, and there was resolution of CME post laser. As you can see, the patient is stable at follow-up with well lasered peripheries in both the eyes. Second case is of a 31-year-old male with vitreous hemorrhage in the left eye, multiple aneurysms seen along the vessels in both eyes. So ipsosity shows CNP areas in superficial plexuses, and larger CNP areas are seen on FFA in both the eyes. So because of this extensive CNP, he was lasered, and on subsequent follow-ups, he further developed CNP areas which was subsequently lasered, and now patient is doing well with BCVA of 6.6 and 6. Coming on to the third case is a 10-year-old child with a BCVA of 6/60 in the right eye, 6.6 and 6 in the left eye. Multiple hard exudates with retinochoroidal anastomosis is seen in the right eye. Left eye hard exudates were seen close to the fovea. The right eye has got a presence of CNVM. Fundus FFA showed presence of capillary furning in both the eyes. On follow-up, we had developed cystoid macular edema, and in view of inflammatory pathology, we had given an injection IVTA to which the CMA responded. Left eye also showed hard reduction in exudates seen both clinically in both the eyes. And the case 4 is of a 32-year-old male with features of IR1 in both eyes. On investigations, he had very less CNP areas, and we decided to observe this patient in view of no extensive CNP areas. So a comprehensive literature search shows no fixed algorithm or management protocol in these cases. Multiple treatment modalities have been shown, which include corticosteroids, anti-VEGF injections, biologics, DMARDs, as well as multiple anti-inflammatory drugs. A study group suggested that there is no true neuroretinitis in these cases, and that the exudative maculopathy is because of the leaking lipid exudation from the microaneurysms. So to conclude, IR1 syndrome is a rare retinal vasculitis disorder of unknown etiology with diversity in treatment approaches and final outcomes. Multimodal imaging is effective in the diagnosis and management of these cases, and close follow-up and prompt treatment is crucial to save vision in these cases. Thank you.
Thank you, Parth. Nice photos. How will you differentiate from labors and adult coats?
Yes, sir. Generally,
because the first one looks like.
Correct, sir. But labors and coats,
adult coats, yeah,
will have usually unilateral presentation. Plus, the aneurysms, the location of the aneurysms is pretty peculiar. Along the optic disc, generally they are not found in coats. They will be found even further at the arcades and even beyond, sir. So the location
the
of
third one did not have anything that were you lasered, no? Nice.
Yes, sir.
Even sickle cell retinopathy can something like that.
Yeah.
Yes, sir.
So that.
Prospective study, retrospective?
Retrospective.
Observational.
Observational study. Chart review, sir. Comparison.
IR1 is a diagnosis of exclusion.
Exclusion, sir. All these patients had a negative workup, and vasculitis workup was also negative.
That is, even the other things will not get any positive workup, labors, clinical only.
Yes.
So then there was neuroretinitis also. Did you do some VEP or something in any of these patients?
Yes, man. All of them had a neuro-ophthalmology referral, and there was no specific cause. They ruled out all the infective causes of neuroretinitis.
Was the latency and all these things affected in them?
No, ma'am. No, VEP was not actually affected. Not in all cases VEP was done. A couple of cases VEP was done.
Just the latency or something, they were normal?
No, they were normal, ma'am, in these cases.
In fact, in IR1, the term neuroretinitis
is a misnomer.
It's
a misnomer, ma'am.
Because every case of retinitis and optic neuritis, they always have a latency effect.
Yes, ma'am.
Thank you, Parth.
Thank you, sir. Thank you, ma'am.
We will go to the next one by Dr. Retina. Yeah. Ciliary body melanoma presenting with neovascular glaucoma in a patient with oculodermal melanocytosis.
That one, huh? Good evening, everyone. I am Dr. R. Renita, presenting to you a case report on ciliary body melanoma. A 53-year-old female presented with complaints of gradually progressive, painful loss of vision in the left eye for 6 months. History of redness, watering, and severe excruciating pain was present in left eye, which was subsided with medications. There was history of headache, and no history of flashes or floaters. On general examination, the patient was moderately built and ill-nourished. There was no pallor-icterus cyanosis, clubbing or lymphadenopathy, and the vitals were stable. On local examination, there was hyperpigmentation of the skin over the eyelids, forehead, cheek, temporal region, and the left side of the face. Head posture was normal, face was asymmetrical. On examination, the right eye vision was 6/36, and the rest of the examination was normal. The left eye examination, the visual acuity was perception of light was present with projection of light accurate. The lids and neck side, there was hyperpigmentation of skin over the eyelids. In the conjunctiva, there was diffuse conjunctival condition with a sentinel vessel at 10 to 11 o'clock position. There was diffuse hyperpigmentation with the florid neovascularization of iris, and there was multiple hyperpigmented scleral patches present in the superior and the inferior quadrants. The cornea, it was hazy and it was edematous. The anterior chamber, there was a variable antechamber depth with 4 millimeters hyphema. There was posterior synechiae present in 6 to 8 o'clock hours with ectropia and uvea. Pupil was slit-like with a vertically oval pushed temporally and not reacting to light. The intraocular pressure, the eye was hard on palpation and confirmed the digitally high IOP. Could not be measured with non-contact tonometry and was 41 millimeters mercury with Goldman applanation tonometry. This is pictures denoting hyperpigmented scleral nodules present in superior and inferior quadrants. With gonioscopy, there was no evidence of neovascularization as was seen. It was a closed angle in the left eye, and the lens showed nuclear sclerosis grade 1. With a dilated fundus examination, there was no view in the left eye. Summary: a 53-year-old female with complaints of gradually progressive painful loss of vision in left eye. Since 6 months, associated with retinous watering. There was hyperpigmentation in the left side of the face with multiple hyperpigmented scleral patches with florid neovascularization of iris. B scan showed large hyperlucent and hyperreflective supranasal mass just behind the lens, extending till the equatorial region. MRI orbit confirmed ciliary body melanoma with no extraocular extension. LFT and CECT revealed metastasis to the liver. The patient have been referred to enucleation and been followed up with chemotherapy and radiotherapy. Uveal melanoma is a discussion. Uveal melanoma is the most common primary intraocular malignant tumor arising from the melanocytes of the uveal tract. Liver metastasis is common with very poor prognosis. Ocular and dermal melanocytosis is a congenital periocular pigmentary condition that can lead to development of uveal melanoma, estimated at 1 in 400 affected patients. In advanced cases of uveal melanoma, patients may present with secondary glaucoma due to extension of the tumor into the angle, pigment-laden macrophages causing blockage into the trabecular meshwork, or anterior displacement of the lens iris diaphragm. Ocular dermal melanocytosis is a congenital hyperpigmentation of the facial skin in the first and second division of the trigeminal nerve. And collaborative ocular melanoma studies suggest that medium-sized tumor can be effective with radiotherapy and enucleation. I like to conclude that by a study that patients with ocular dermal melanocytosis should undergo routine ophthalmological examination in order to carefully monitor for glaucoma and melanoma.
Thank you.
Thank you.
Any? Okay. Next, you can. Dr. Samiksha Agrawal is presenting. Dr. Samiksha Agrawal is not there. Dr. Samiksha Agrawal. Then Dr. Sophia. Dr. Sophie will be presenting on effect of Sophie will be presenting on effect of OCT parameters of uncertain significance in wet AMD treated with intravitreal anti-VEGF, right? Yeah.
A very good afternoon, good evening to everyone. Today I'll be presenting a paper on effect of OCT parameters of uncertain significance in wet AMD patients treated with intravitreal anti-VEGF. Wet AMD is characterized by various findings on OCT, likely subretinal and intraretinal fluid, choroidal neovascular membrane, pigment epithelial detachment, retinal pigment epithelial tears, deciform scarring, and loss of ellipsoid zone. And there are also certain other OCT parameters which are multifactorial in origin and whose significance is not yet determined, like pseudocyst, outer retinal tubulations, choroidal cavern, prechoroidal cleft, and onion sign. The aim of my study is to analyze the effect of OCT parameters of uncertain significance on visual outcome in wet ARMD patients treated with intravitreal anti-VEGF. My study design is a prospective cohort study. Duration was from September 2022 to December 2023. Sample size includes 22 eyes of 14 patients. My inclusion criteria include patients, wet ARMD patients having central foveal involvement, and those who are treated with at least 3 doses of intravitreal anti-VEGF. And the exclusion criteria are those patients who have had history of vitrectomy or any significant media opacities. My material and methods in there is a comprehensive ophthalmic evaluation was done and baseline visual acuity was noted. The OCT was done and all findings suggestive of wet ARMD were documented. And intravitreal anti-VEGF was given monthly, and visual acuity testing and OCT parameters were done at every 1 monthly follow-up. For final analysis, the baseline and 1 month post third dose anti-VEGF visual acuity and OCT parameters were compared. My results, the age of my subjects, they range from 52 to 87 years. The males outnumbered the females, and there are 4 patients who had bilateral involvement. The results, mean baseline visual acuity was 1.29 logMAR units, and based on the OCT parameters, I have a patient who have CNVM, total lysis 18, intraretinal fluid 14, subretinal fluid 11, PED 9. And the results of the uncertain significant parameters, onion sign was seen in 2 patients, choroidal cavern in 1, prechoroidal cleft in 2, and intraretinal pseudocyst in 4. The results comparing the baseline and final visual acuity according to the OCT parameters, there has seen to be improvement of vision in all the findings like CNVM, intraretinal, subretinal fluid, and PAD. However, in the findings, onion sign, there is improvement, slight improvement. However, in choroidal cavern, prechoroidal cleft, and intraretinal pseudocyst, there was no improvement. Discussion in the present study, 2 eyes having onion sign showed visual acuity improvement from 1.55 to 1.24 logMAR unit after 3 doses of intravitreal anti-VEGF. These were also seen in certain other studies. They have also proved the same findings. And the presence of choroidal caverns, prechoroidal clefts, and intraretinal cyst in the present study showed no improvement in the visual acuity, which has also documented in other studies. And conclusion is, amongst the OCT parameters of uncertain significance, only the presence of onion sign showed mild visual acuity improvement, whereas the presence of prechoroidal cleft, intraretinal pseudocyst, and choroidal cavern did not show any significant visual recovery. Thank you.
How many times this onion sign is documented in literature, or is it your term?
It was documented in that literature. Which
Where, in which one have you quoted that reference?
Onion sign.
Yes. I have quoted. I have. But I'm not.
This total number of cases were 18.
No, sir. 22 eyes of 14 patients.
22 eyes.
Yes.
So,
Actually,
no,
there were less difficult patients. There were
But
few
good,
patients
good
of
effort
better.
in presentation.
No, you have to look for that, then only you will see, especially in chronic cases. So ideally, to see the significance, you need large numbers. No?
Yes, sir.
Especially
That was a
chronic
big
cases.
limitation.
Like another
actually.
one is outer retinal tubulation, ORT.
Cohort?
So cohort. So cohort is a prospective study. Like we study prospective.
This is all prospective?
Ha, sir.
Okay, you have selected all cases and just...
Yes, sir.
Cohort. Is it simple? Thank you.
Thank you, sir.
Dr. Arushi Agarwal? That's it. Dr. Arushi Agarwal will be presenting on a review of treatment modalities in choroidal hemangioma in our experience.
Good evening, judges and everyone present. I'll be presenting choroidal hemangioma, our experience. So choroidal hemangioma is a rare benign vascular tumor which is a hematoma that is present since birth, and it is composed of tissue elements that are normally found in a given location. Cavernous type being the most common, followed by mixed and then capillary. It can be a circumscribed tumor or a diffuse cavernous hemangioma, and asymptomatic tumors require no treatment. But tumors with subretinal fluid threatening the macula, exudative retinal detachments are the ones that require treatment, and long-standing retinal detachment can lead to poor outcomes. So the various treatment options available are photodynamic therapy, transpupillary thermotherapy, anti-VEGF agents, and radiotherapy either in the form of plaque or external beam radiotherapy. Due to rarity of this condition, a small series needs documentation to understand the extent of the existing diversity. So ours was a retrospective study where we analyzed 5 cases of choroidal hemangioma who presented to the retina clinic of our institute. The age group ranged from 20 years to 65 with a mean of 39 and a male to female ratio of 4:1. The mean baseline vision was a logMAR of 1.76 and a final mean was a logMAR 1.1. The mean tumor height was 4 millimeters. Single treatment session was given to 3 patients and 2 of them required multiple sessions. We used triple T in 1 patient, PDT in 2, brachytherapy in 2, and external beam radiotherapy was used in 1 patient. So our first case was a 55-year-old man who presented with metamorphopsia and decreased vision with a presenting visual acuity of logMAR 0.5. We went ahead giving PDT with verteporfin, and after full fluence of PDT, we were able to achieve a logMAR of 0. The second patient was a 40-year-old male, but when he presented, PDT was not an available option, so we went ahead with iodine-125 brachytherapy. 30 gyri was delivered to the apex. Post brachytherapy, disc pallor was present, and we can see that there was a reduction in the disc edema, and the final visual acuity was logMAR of 1.2. The third was a case of a 20-year-old boy with diffuse choroidal hemangioma, a known case of Sturge-Weber syndrome. He presented in his left eye with a visual acuity of hand motion close to face. We went ahead with an iodine-125 brachytherapy. Post brachytherapy, there was a reduction of edema, and the final visual acuity was the same as the presenting. This same boy developed choroidal hemangioma in his other eye with the fluid present. So first we planned the patient with propranolol for 3 months, followed by full fluence PDT, and we gave an anti-VEGF agent Razumab. But unfortunately, the patient presented with a recurrence 6 months after, and we delivered fractionated EBRT. A total dose of 20 gyri was routinely delivered, and the choroidal irradiation was done using a lens sparing technique. Our fifth case was a 65-year-old female who presented with decreased activity. The fundus photo and the ICG of the patient shown. There was a subretinal detachment present, and ICG shows a lacy hypersinus with late without. Finally, after 3 treatment sessions of triple T, we were able to achieve a visual acuity of 20/40 and a reduction in edema. So discussion comes that the macular circumscribed tumors, PDT, give us the best anatomical as well as the functional outcome. However, the limitation being that in the current practice is the non-availability. Extrafoveal tumors, triple T is the tool of choice. Multiple settings are required, and we need to closely follow up these patients as edema can recur. Radiation is coming up in a big way for management of these tumors. Plaque brachytherapy is there, and in cases of refractory and diffuse tumors, fractionated EBRT can help us attain an anatomical reduction. So this tumor can have diverse clinical presentation, and the treatment needs to be customized for each patient. PDT appears to be an excellent modality for the macular tumors. Propranolol, anti-VEGF, triple T, I have a definitive role to play in the choroidal hemangioma treatment, and fractionated is considered for diffuse as well as refractory cases. Thank you.
Only one was diffuse, others were circumscribed, right?
So two the same boy had diffuse in both his eyes.
Okay, that are 2 numbers.
Yes, sir.
Okay, so they had this EBRT and.
So we tried multiple modalities: propranolol, anti-VEGF, and final EBRT in one eye.
Sturge-Weber case.
Yes, sir. Thank you.
Thank you. And next is Dr. Karishma Tendulkar. Choroidal vascular perfusion analysis in central serous chorioretinopathy using wide field ICG.
Thank you, sir. Good evening. I'm Dr. Karishma, and I'll be presenting on the choroidal vasculature perfusion analysis in CSCR using wide field ICG. So CSCR, as we know, is a localized serous detachment at the macula with an associated underlying focal or multifocal PED. There have been multiple risk factors associated with the disease, including the male gender, exogenous steroid use, endogenous hypercortisol conditions, type A personality. There are several theories regarding the pathophysiology behind the disease, including anatomic factors like RP integrity loss, RP dysfunction, pachychoroid theory, and also choroidal vascular abnormalities. A recent study by Spade et al. Coined the term venous overload choroidopathy. So they included a group of disorders in this, including CSCR, peripapillary pachychoroid syndrome, vortex vein congestion, carotid cavernous fistula, amongst others. And they said that the pathology behind these diseases lies in the fact that there is a venous overload, there's a congestion which leads to these conditions. So with this in mind, we carried out a study to identify the choroidal vasculature changes in CSCR using wide field ICGA. This was an observational cross-sectional study done in 40 eyes with CSCR. We excluded the patients who had undergone any treatment, so we'd taken the treatment-naive patients and we subjected them to wide field ICGA and FFA on the Mirante NIDEC. So the Mirante machine has a 163 view, which is a wide field view. The analysis was then done by 2 independent observers. So what did we find? We found the following results. We saw that the patients had dilated vortex veins, vortex vein ampulla dilatation, posterior extension of the vessels, and intervortex vein anastomosis. So these are some of the images. So the patients in the early phase of the ICGA showed dilated vortex veins. These were seen more in the superior quadrant, and as seen in the last image, there was also posterior pole extension. The ampulla dilatation was also noted in some of these cases. As you can see, the posterior extension of the vessels, what usually happens is there is tapering of the vessels when they reach the watershed zone, which is between the inferior and the superior vasculature. However, in some of the patients with CSCR, we noted that the physiological tapering was not seen and these vessels were dilated even at the posterior pole. We noted that they had intervortex vein anastomosis. That means it could be suggestive of vascular remodeling because of the venous choroidal hyperperfusion. There could be an alternate drainage pathway which is formed in these areas. The FFA areas, wherever there were leakage, also corresponded to areas of vascular hyperperfusion on the ICGA. So the origin of the abnormal pachychoroid vessels appeared to extend from outside of the standard viewing parameters. There were recent studies by Pang et al. Where they reported similar findings of vessel dilatation along the entire drainage course, extending all the way up till the ampulla. Hirare et al. Also found that there was a higher mean choroidal vessel density. They said that the quantity had not increased, but the vessels that were already present had been congested. And Hiro and Kishi reported drainage asymmetry in the vortex veins. So the take-home points are that extensive choroidal involvement may be seen on wide field ICGA in patients with CSCR, and hence this examination is essential in these patients. We also saw that choroidal hypopermeability due to vortex vein congestion could lead to fluid egression into the subretinal space, and an intervortex vein anastomosis may suggest remodeling.
This study was done earlier also? Any review literature?
So it's not been done in a lot of places. The studies that I mentioned, it's a relatively new technology. Not a lot of places have a wide field system to view these changes. So,
but in any case, you have to see the center only.
Right, ma'am. So what they had seen, they saw that these changes could also be predictive. Like in a lot of patients who may not have had CSCR at the time of presentation, may have these changes in the fellow eye as well. So they could be predictive, and they could be in the future biomarkers of pachychoroid disease as well, which can help to predict.
Fellow eyes have changes, yes, that's true.
Which could predict that in the future these patients could develop a CSCR.
It is not like that. Actually, Spade has described the venous overload choroidopathy,
yes,
and these findings have been described already. The importance is not predicting other eye. It is the treatment modality, like decompression, all these things. So
like
probably those cases,
syndrome,
the importance of this study is regarding the treatment modalities.
Right, sir.
Anyway.
Okay, sir. Thank you. Thank you.
So we'll go to the last presentation by Dr. Krishna Priya Kaimal. She is talking on microalbuminuria and low HB as risk factors for occurrence and severity of diabetic retinopathy.
signals, apprentice.
Good evening, everyone. I'm going to present my paper on the topic microalbuminuria and low hemoglobin as the risk factors for the occurrence and the severity of diabetic retinopathy. As you all know, diabetic retinopathy is a common ocular complication of diabetes mellitus, and it is considered to be one of the leading causes for the visual loss and visual impairment globally. And it is documented that more than 77% of patients who survive for over 20 years with diabetes mellitus are affected by retinopathy. Aim of the study is to establish the correlation of microalbuminuria and low hemoglobin in type 2 diabetes with the occurrence and increasing severity of diabetic retinopathy. And it is a prospective cross-sectional study. All the patients with type 2 diabetes and patients with informed consent are included in this study. And whereas pregnancy, accelerated hypertension, active systemic infection, coexisting ocular disorders like uveitis, opaque or hazy media, and the retinal disorders like retinal artery or vein occlusions and retinitis pigmentosa, vitreoretinal degenerations and dystrophies, high myopia, and recent ocular surgeries including vitreoretinal surgery for the causes other than diabetic retinopathy are excluded from the study. A detailed history including previous photocoagulation and the current medication was obtained. All the subjects underwent a detailed physical and ophthalmological evaluation, and BCVA was assessed using an illuminated Sillens chart, and the optitis macula and the retinal background were evaluated using IDEO and slit lamp biomicroscopy. And the patients were divided into two groups, that is group 0 without diabetic retinopathy and group 1 with diabetic retinopathy of any severity. And the grading of the severity of diabetic retinopathy was done using modified early treatment diabetic retinopathy study protocol. And for the purpose of analysis, like patients in group 1 was further subdivided into mild to moderate NPDR, severe NPDR, and proliferative diabetic retinopathy. And there were 67 participants in our study, and out of the 67, there were 41 males and 26 females, and the age of the patients ranging from 35 to 80 years, with mean age of the patients in the study was 56.4 years. And as you can see, diabetic retinopathy was found in 29 patients, and out of these 29, 17 had mild to moderate, 6 had severe NPDR, and 6 had proliferative diabetic retinopathy. And this is a table showing microalbuminuria compared with the severity of diabetic retinopathy. As you can see in this table, lower range of microalbuminuria was more common in mild NPDR, and higher range of microalbuminuria was more common in proliferative diabetic retinopathy. And this is a table showing anemia in comparison with severity of diabetic retinopathy. Hemoglobin 12 or above was more common in mild NPDR, and hemoglobin 8 or below was more common in severe NPDR. So in our study, there was a significant association between microalbuminuria with the occurrence and severity of diabetic retinopathy. In type 2 diabetes, microalbuminuria may not be only a marker of renal disease, but also have a close association with generalized cardiovascular disease, increasing the risk of myocardial infarction or stroke. So this study also established correlation between diabetic retinopathy and low hemoglobin, and low hemoglobin was an independent baseline risk factors for the development of proliferative diabetic retinopathy and severe visual loss. So the presence of microalbuminuria should warn the treating physician of the need to monitor the retina along with the kidney function. So this in turn may reduce the occurrence of irreversible visual loss due to diabetic retinopathy. So low hemoglobin level, which is common in patients from developing countries like India, needs to be detected and treated, so thereby reducing the risk for developing diabetic retinopathy. Thank you.
Review of literature. Has shown me review of literature. The study was done from the earlier study was done 15 years back. Forget about how microalbuminuria are done.
So 24-hour urine.
What is new in your study that we don't know? Something new?
Because that's known that if more severity, more microalbuminuria and more severe the diabetic retinopathy.
What is new?
All are correlated.
That is when we present our study, what is new? Some points we can.
You could have done new. How many percentage diabetic patient get the microalbuminuria done? That is the percentage will come. Not majority of people do it. That is another thing. And the RP center we have done the study earlier also. And you could have correlated with the nephropathy, neuropathy. All the presenter has done they have got very good confidence presenting.
That is
They have done a detailed work.
Generation are presenting whatever they are presenting in full confidence. Good. Talia.
And detailed study.
Are Talia. No, whatever they are present.
Yeah.
This is just you are just,
So,
trying to
just
do
a few advices to the young generation. They are very good, I know.
Very good.
Yeah,
but do original work, more and more collateral things.
why I am doing this study is not for you also.
you,
Just
all.
You can take seat.
Hi.
Thank you very much. It is just comments.
Photo, jana nahi, photo.
Just comments generally. Why we are doing this study, that you should ask yourself. What is, even if it is a negative outcome, like this is not related to this, that is a outcome. So so there is no point in doing same non-thing already. So that is one thing. And when you present also this, what I suggested some time back, you should go into the study and don't waste time in other factors. And you should highlight what is the outcome of your paper and how it is clinically important. These things you should highlight. So just few advice. Anyway, like sir said, all of you are presenting very
confidently
excellent.
and detailed study. Very nice studies.
Very nice study. Younger generation are presenting whatever they are presenting with good confidence.
Yeah. So thank you very much.
Photograph.
Yeah.
All presenters should come.
There is no other presenter who has come. No, later Samiksha.
No, two people are absent. Three.
Three are absent.
Sanskrita Sinha is not there. Raminder Singh is not there. And Samiksha Agarwal is not there, right? Three are not there. Okay.
Photo.
Yeah.
You can collect.
All presenters should come.
Sure.
आ जाओ आइए कम आ जाओ
Yeah, group photo.
आ जाओ पास में आ जाओ
Closer.
आप आ जाओ
So that
आ जाओ all
everybody comes in.
good
Pose again.
बच्चों से कहना हम लाए हैं तूफान से किस्ती निकाल के ये देश को रखना बच्चों से खा लिया बिल्कुल बच्चे के लिए तो इसमें संभाल लें एक मिनट कैलकुलेट कर